StarMed.
Okay, good morning and good evening. We'd like to welcome everyone to today's webinar. We hope that everyone in the US had a wonderful, long 4th of July weekend. My name is Brian Alexander, and I'm StarMed's Regional Manager for the US.
Next speaker is Dr. Ahmad. He's an endocrinologist from the Thyroid Clinic, Salt Lake City, Utah. He focuses on the diagnosis and the non-surgical treatment of thyroid and parathyroid disease. He will introduce a very interesting case, RF ablation of primary hyperparathyroidism. Dr. Ahmad, please.
Thank you, Professor. Thanks for all your teaching. I will start. Brian, do I have control? Brian? Brian, can you hear? Oh, yeah, perfect. Thank you. So, yeah, I'm going to go over some facts which are a segue into our discussion later on, so bear with me for a minute. So, primary hyperparathyroidism is a fairly common condition in the US and around the world. Overall incidence expected to be around 0.7%, but in the postmenopausal female category, it's around 3 to 5%. Multi-gland disease, which we often talk about, is about 10 to 15% of the cases. Majority of these are single adenomas. 80% of the diagnosed patients, again, 80% of the diagnosed patients have no real symptoms or complications. There are association studies that we have about increased risk of kidney stones, fracture risk, stroke, cardiovascular disease risk, but we do know that most mild primary hyperparathyroidism is asymptomatic, and treating that does not have any meaningful impact on quality of life. That's a very important thing, because that's why we're in medicine. We're trying to improve quality of life. We do know that primary hyperparathyroidism, when treated surgically, does improve bone density, but that's equivalent to what medical therapy does. So it's not found to be superior, and there's no long-term longitudinal studies looking at fracture data. There is also no real clear evidence that surgery for primary hyperparathyroidism in a persistent, reliable way improves kidney function. And we also know that only 5% of patients that are untreated for primary hyperparathyroidism develop severe hypercalcemia. So the gist of what the numbers are telling us, that most of the times there can be a lot of asymptomatic patients with a meandering, slow, smoldering version of disease with no clear therapeutic benefit for intervention. And for that reason, a lot of our patients are shunted towards medical therapy. Now, I decided to discuss this case because in endocrine circles, and technically I'm an endocrinologist, but I've only done thyroid and parathyroid diseases for the last 10 odd years. But this study did catch my eye. And this is about the use of medical therapy for management of primary hyperparathyroidism, because you're dealing with two issues when you deal with primary hyperparathyroidism. One is the calcium and parathyroid hormone derangement that you're trying to fix as a marker of success. And then you're also trying to fix the bone density, which is a big concern for you. Now, this study looked at Denosumab and cinacalcet. Denosumab, as you know, is an anti-resorptive agent, rank ligand inhibitor, and cinacalcet is a calcium sensing modulator. So they combine these two because cinacalcet has been known to normalize calcium and has some impact on lowering PTH levels. Denosumab is a very powerful agent for addressing bone density issues. So this study is all the rage in osteoporosis circles. And this looked at 16 patients who were randomized to Denosumab, 15 to a combination, and 15 to the placebo. And what they showed was that bone mineral density did improve in the group receiving Denosumab plus cinacalcet, but the side effect rate was around 6.2%. And the cost of Denosumab is around $1,400 each injection. Duration of therapy is an interesting question, because we have now realized very clearly that Denosumab cannot really be stopped. Once you start it, you're pretty much on it, because if you stop it, the bone density declines rapidly and your fracture risk goes up. So what I'm trying to say here is that medical therapy for primary hyperparathyroidism is not a very straightforward, low-risk intervention. It has serious consequences. I'll move on to the next slide. So just looking at where the guidelines are, and the 4th International Workshop on Asymptomatic Primary Hyperparathyroidism also mentions the use of cinacalcet. The cost of this is around $60 a day, and it has no meaningful effect on parathyroid hormone levels long-term, unless if you give it for around 4 or 5 years, and no effect on bone mineral density. And if you recall what I was just saying, the most important thing with primary hyperparathyroidism that drives most of our therapeutic decisions for the majority of asymptomatic patients is bone density. So this drug has no real effect on bone mineral density, yet it's still recommended for use, and it costs about $60 a day. The cost of 1 year treatment with this drug is upwards of $7,000 US, and it does not reduce urine calcium, so kidney stone risk remains. Bisphosphonates do the same thing, and the side effect profile for cinacalcet is around 20 to 30%. I'm trying to argue that there is a third way for all these patients, and that's what we're going to talk about. Another thing that we see frequently at our practice, me and my partner, Dr. Al-Jamal, we do a lot of parathyroid localizations for majority of the head and neck and generally NT surgeons in our area. Quite frequently, we'll find these intrathyroidal parathyroid adenomas. And when they end up going for surgery, more often than not, they end up having a sacrifice hemithyroidectomy at the same time, because sometimes it's hard to express the parathyroid gland that's kind of embedded itself deep inside the thyroid parenchyma. So again, this is another indication that I think RFA could work for. This particular patient that we're about to do Parathyroid RFA on next month has had 2 surgical consults, and both times she's been told that she'll probably need a right hemithyroidectomy also. So she's decided to go radiofrequency ablation route in order to prevent sacrifice of her right-sided thyroid gland. This is a case, the first case of Parathyroid RFA that we did, me and my partner, Dr. Jules Al-Jamal, whose contribution to this is invaluable. I believe this is the first Parathyroid RFA done in the US. Might be wrong, but I haven't seen anything in the data anywhere. So bear with me. This video is kind of abridged and time-lapsed, but it still takes a little while to load up and get going. Brian, is it playing? Here we go. So some surface marking. This is a left inferior parathyroid adenoma in a 67-year-old patient with a calcium of 11.5 and an intact PTH of 106. We did perform a left inferior parathyroid adenoma biopsy. A lot of surgeons will say, you should not do a biopsy. I disagree with that. We did present our data and results at ACE. If a 27-gauge needle is used with 2 passes done, there was no evidence that fibrosis could be detected or if operative time changed. So we frequently will do it when we're trying to be 100% certain where the adenoma is. So in this case, we did a 27-gauge needle ultrasound-guided biopsy, 2 passes, and the washout was more than 39,000 picogram per ml, confirming that adenoma was there in the left inferior tracheoesophageal groove. So again, as Dr. Baek just mentioned, the recurrent laryngeal nerve is right there in the tracheoesophageal groove, a little more lateral on the left side to the right. So our goal was to dissect the parathyroid adenoma away from the recurrent laryngeal nerve. And we used a 25-gauge needle, again using very cold D5W. You can see the 25-gauge needle where the arrow is pointing, and under the expert guidance of my partner, Dr. Al-Jamal, who's steadier hands than mine, we started the hydrodissection. By the way, this is the same technique we are using for thyroid cancer recurrences in the recurrent laryngeal nerve. We've performed that also at our center for medullary cancer. And so as you can see, this is D5W that's being slowly injected, and the adenoma is, we're trying to dissect it away from the groove. You can see the tip of the needle almost underneath the adenoma. And here we go. And so our goal is to somehow lift it above. We just made a little plane there, and then Dr. Al-Jamal was able to get underneath the adenoma. And as you can see, we had a pocket there. And just like Dr. Baek just mentioned, we started giving 15 to 20 cc's boluses as necessary to keep it away from the recurrent laryngeal nerve, very cold D5W. And that you can see we left the needle there so that we could keep the plane dissected away from the nerve. And now on the left-hand corner of your screen, in a minute you'll see we used a 0.5 centimeter tip with 35 watt power. Our goal was to ablate all of the adenoma. This adenoma was around about a centimeter in volume all over, so decent sized. It wasn't that small. As you can see, the hydrodissection is continuing. The water, as Dr. Bake just mentioned, does get reabsorbed, so you have to continue a little bit of an infusion type thing going on. We do normally try to ablate all the vascular supply to such lesions, artery first, vein second, again as taught by Professor Bake. So this is the adenoma, and you can see the tip of the antenna inside the parathyroid, and 35 watt power again was applied to the area. And as you can see, works pretty well. We reevaluated and continued the ablation until all sections of it and all vascularity was appropriately addressed. We're trying to get to the lateral margins of this because the vascular supply seemed to be more rich in that area. But again, we only needed 35 watts of power to have an avascular picture at the end and a hyperechogenic look throughout the adenoma to confirm that we had been successful. At the same time, as you can see down here in the plane, we were injecting fluid, so the dissection and the separation was always present. Again, as I said, this is the time-lapsed abridged version. The real version took a lot longer. You have to be very careful in these small movements. It's a sensitive area. So post-operatively, the PTH was 36.3, calcium was 9.1. She has been followed up for now 6 months. Calcium remains in the 9s, and the parathyroid hormone level is normal. She says her symptoms are improved, but I think that's rather subjective because she didn't really have any symptoms before. We continue to monitor the voice throughout this procedure. That is our protocol for all the benign thyroid lesions we also do. We've never done any cases under general anesthetic, just local anesthetic and a little bit of conscious sedation where necessary. Here's the picture of the adenoma about a week ago. So 95% or more volume reduction. It's a very small, and the calcium remains normal, and parathyroid remains normal. So to end this, I would say that the cost of radiofrequency ablation in a single setting is less than half of what medical therapy is right now proposing. We don't have any data on bone mineral density. That obviously will take time. And another point that people will raise is, what do you do about multi-gland disease? Not every surgery center in the US follows intraoperative PTH levels. And if you have documented localization in one area with biopsy, or with two concordant studies like a MIBI and an ultrasound, most data shows that you don't really need intraoperative PTH monitoring because you're dealing with one adenoma. Recent research done in Korea by Dr. Yoon-Ju Hwa, she's going to present an abstract at the World Thyroid Cancer meeting next year. She did about 10 parathyroids recently, and all 10 of them have normal calciums, normal PTH levels 6 months later, with one minor complication. So I argue that this technique is superior to medical therapy. It's cheaper than medical therapy and safer than medical therapy. I'm not saying this is a replacement for surgery where indicated, but the question about where surgery is indicated remains slightly controversial. I'll stop here and listen to any questions that we have. I think I'm going to start at the top.
Yeah. Yeah, thank you very much, Dr. Ahmad. As far as I know, this is the first case of RF ablation of primary hyperparathyroidism in the United States. Is it right?
I think so. I haven't seen anyone else publish anything about this. This is the first one. But this technique did teach us a lot, and we were able to apply it to hydrodissection for thyroid cancer recurrences in the tracheoesophageal groove. So hydrodissection is really useful for a big portion of our patients, I think, in the future.
Yes, thank you. Any questions or comments from the speakers? Question is, your mechanical stimulation of parathyroid adenoma can induce spillage.
Spillage of parathyroid
Spillage
hormone?
out of parathyroid hormone that can induce transient hypoparathyroidism.
Yes, we think technically that's possible, but the same thing happens with manipulation of parathyroids when bilateral exploration is going on. Parathyroid hormone doesn't have a very long half-life, so if you're able to ablate this successfully, if you check 30 to 60 minutes later, so that spillage should be transient at best. Again, I'm not an expert in that in that way. That I haven't done those types of studies, but again, intuitively thinking, parathyroid hormone has a short half-life. So if you're successful at ablating it, I don't see that being a major concern, but I'm open to what your experience is in Korea, since I've only done one case.
Another question from the floor is a vascular ablation technique. Do you ablate any feeding vessels during RF ablation?
Absolutely. Parathyroid adenomas have typically a polar artery that you can see go in and out, and our goal is to go with the artery first and then the vein second. We were expecting to use higher power for artery and vein because there's a heat sink effect and they can transmit all the thermal energy away. But in this case, we were successful even with 35 watts, and we went for the artery and then the vein. And we continued this procedure until all parts of the adenoma were ablated with ultrasound echogenicity noted, and all the vascular supply was pretty much extinguished. So yes, absolutely, we were cognizant of that, and that was one of our goals.
Yes, thank you. See you next webinar. Thank you.
Okay, thank you.
Thank you so much.
Thank you. Bye-bye.
Thank you.
Bye.